Turn off my phone.
Hello, everyone. Doctors in Politics and myself, Dr. Gogu, we're very pleased today to have Dr. Ed Michelson, who's the chairman of the Department of Emergency Medicine at Texas Tech in El Paso, where they dealt just recently with a heavy surge of COVID deaths and COVID cases. He's going to be here today to talk us through the trends of the current statistics of the COVID pandemic that's there nationwide, and we're very fortunate and lucky to have him. You might have seen him on Meet the Press, CNN. I've read about some of his quotes in the New York Times and the Washington Post, so we're very grateful to him and him being a leader during this time. So thank you so much, and we'll have you start.
Thanks. Thank you very much for inviting me and including me this evening in your series. Tonight, I'd like to share with you some of our experiences here in El Paso and talk a little bit about what I've been living the last 6 months as COVID has finally come to West Texas. I'm going to talk a bit about our experience with our surge, which peaked around the second week of November, and it's actually looking better here. And I hope this will bring some hope to those of you who are yet to hit your peak, because I know in many cities the number of cases is going up rapidly, the number of people in hospitals going up, and I think you all will be experiencing what we've lived in the last several months. So again, I'm at the Paul Foster School of Medicine of Texas Tech University Health Sciences Center here in El Paso, Texas. We're at the very western tip of Texas, nestled right next to southern New Mexico and right across the border from our sister city, Juarez. Texas Tech University Health Sciences Center is an independent university. We're in the Texas Tech system. The main home of Texas Tech, of course, and the Red Raiders is in Lubbock. But here in El Paso, we have the Paul Foster School of Medicine. We also have the Gail Grieve Hunt School of Nursing. And we are just launching a new dental school, which will be taking its first class this coming year. So I have many roles here at Texas Tech. As was mentioned, I am the chairman of the Department of Emergency Medicine. I'm also the chief of the emergency department at University Medical Center. UMC is the county hospital, and we are the only not-for-profit hospital in El Paso. The remaining hospitals are all owned by Tenet, as well as the Health Corporation of America. So they're all for-profit institutions. The one exception being William Beaumont Hospital, which is the Army hospital here at Fort Bliss. I'm also a search committee member of the Border RAC. Texas is divided into a number of trauma regional authorities. And here in West Texas, covering 3 or 4 counties, we're referred to as Border RAC. We stood up a committee to look at the coming surge last spring. We've been meeting regularly, as frequently as daily when numbers were heating up, and I've represented our school on that committee. I'm also the chief medical officer for EPIC, the El Paso Infusion Center. Some of you may be aware of the monoclonal antibodies that have been approved for emergency use authorization. The first one from Eli Lilly, bamlanivimab. We received 1,000 doses separate from hospital allocations as one of the pilot test sites for doing a community-based infusion program. And be happy to talk to you all about that at another time. But the short version is it's going very well. We're referring patients from all of our facilities to one central site to get the bamlanivimab infusion, and we're up to around 300 patients so far. I'm also a member of the El Paso County COVID Task Force. This is a group of physicians as well as community leaders that has been making recommendations to our city and county leadership regarding actions that should be taken relative to reducing the number of cases. So tonight, I'm going to focus on data. Data has been an incredibly important part of my life as we've had to make decisions about how we deploy our staff, how we add capacity, how we deal with exceeding normal numbers of hospitalized patients. And I've been tracking multiple data sources practically daily. Along with that, I've also been sharing my updates and synopses with my staff. So one of the interesting aspects of doing emergency medicine is, we're a 24/7 operation, and I have residents, students, and faculty physicians who are working round the clock 24/7. So there are days that go by when I don't see some of them. As a result, I have been sending out essentially weekly updates to all of them with current graphs, summaries, and my brief synopsis of how I view the data. So they feel connected. They understand what's behind the thought process that we take in deciding how to organize our resources and how to respond, and that they feel informed so that if their friends, their family have questions for them, that they more likely than not have the answers. And if you're not doing that and you're in a position to do so, I highly recommend it. So in terms of making sense of the numbers, let me run through for you in the coming slides different types of statistics that we look at. They come from multiple sources, many of which you see on the media, on the nightly news. Personally, I find the New York Times a great source for information both at the national level as well as at each state level. And I'm a daily reader of the Times section on COVID-19. But the Johns Hopkins Institution also has great resources. And here in Texas, we have a number of state-based excellent resources, as well as here in El Paso. So I'm going to show you a smattering of graphs from each of them. The reliability of the numbers, however, although the graphs look pretty, the numbers aren't always fully accurate. And there's definitely a fudge factor that goes into making sense of the graphs and the numbers that we're seeing. It's also important to get a sense for the interplay between different statistics. So, for instance, the number of active cases predicts the number of hospitalizations. We find that when patients test positive, within about a 5 to 7 day period is when they really start getting symptomatic and start showing up in the hospital. So watching those daily numbers of new active cases, looking at the percent of patients testing positive, helps predict numbers of patients that we're going to be seeing in the hospital in coming days. So here's a list of the types of statistics that we're following on a daily basis. Total cases, you see this reported nightly, numbers of cases in the United States. We now are exceeding 19 million, and I have that coming up. Total cases is a little bit different than active. What is the definition of an active case? This is a derived number. I mean, how do we really know how many people are active? That is a derivation based on the total number of cases and an assumption on how long a patient who tests positive will in fact be active. So no exact measure, simply an estimate. Numbers of patients being tested is incredibly important because if you don't test someone, you don't know that they have COVID-19. Early in this pandemic, a lot of discussion about rate of tests, numbers of tests, not enough tests, and that's probably still true. But it's also true that the more people you test, the more cases you'll find. And we know that there are many patients who are asymptomatic positive and probably not getting tested, so they're not getting counted. Despite that, the percent of patients who do test positive is another indicator of how rampant the disease is in a community. We all hear reports about deaths, and I'll tell you of all the statistics, this one is probably the most unreliable. Here in El Paso County, there's at least 500 patients who have died who have not been categorized yet as dying from COVID. Many reasons for this, one of which is that there can be substantial delays from the time a patient passes away until a death certificate is completed and certified by the medical examiner. The ME's office has been incredibly busy. So daily deaths reported have little comparison to the actual numbers of patients who are dying each day in hospitals, and the totals definitely lag the actual number of people who have died. Another unfortunate fact of COVID is there are probably many more deaths that are occurring this year that never get identified as being related to COVID. that could be as much as 30 to 70%. And if you look back on prior years' death rates by month across the country and compare them to this year, the death rate this year in the United States is much higher, and that number is higher than the number of reported COVID deaths. So that difference is probably a substantial number of COVID-related deaths. Community prevalence, very important. That's one of the factors that local leadership uses to decide whether to introduce increased restrictions on activities, curfews, how many patients can dine in a restaurant. A lot of that is driven by the prevalence of disease in the community as well as hospital utilization. Of all the statistics, hospital utilization is the most accurate statistic for tracking our progress in this pandemic. So, what are the hospital statistics? Well, total number of COVID patients hospitalized, but it's also important to break them down between the number on a general med-surg floor versus the number in the ICU, and the number boarding in the ED, which is not reported anywhere, but probably has the biggest impact on ED overcrowding, waiting times, and dysfunction. The percent of hospitalized patients is also important. At our peak, we exceeded 50% of hospitalized patients being hospitalized for COVID. We're now down into the 20-something percent range, so we've improved quite a bit. But the more patients that are hospitalized with COVID, the less room there is for everybody else. That's also a deciding factor on when hospitals have to cease doing elective surgery and other types of activities which add to hospitalization at a time when you don't have beds. That's a very sensitive discussion for hospital CEOs because that's a source of significant revenue for most hospitals. And then lots of reports, and we're very sensitive to how many available beds are left, both floor and ICU for patients. This is another number that I think is somewhat inaccurate because we've all had to surge. We've all had to create new ICU beds, new floor beds that didn't exist. And some of the statistics on percent of ICU beds being full are based on licensed beds and not surge beds. And finally, the morgue. We're receiving daily reports on how many deceased we're holding in the morgue. That has become a challenge as well and required us to look for other places because of delays in families handling their next of kin's last plans and funerals. So let me run through now a whole list of different statistics to kind of give you an idea of what I'm looking at. I've tried to update these as close as possible to today. Some are within the last couple of days. And we'll take this from the world level through national, regional variations down to the state. I'm going to focus on Texas since that's where I am. I'll show you some of the more detailed data at the county level and then at our local level. So first, at the world level, this goes back to the beginning of the pandemic here, at least in North America, in March, and ends in early December. And you can see how the United States has clearly gone well above the pack of multiple other countries in our surge in the current COVID crisis. Looking at U.S. daily cases updated to today, we've now exceeded 19 million. On December 28th, there was almost 190,000 new cases reported. Notice some of the little squiggles in the data. There is testing variation over holidays. Many fewer patients get tested over Thanksgiving, over Christmas, and that's the primary reason you see these little dips. The reality is something that's much more of a smooth line. So day-to-day variation is less important probably than the weekly average or the biweekly average. The other number that's important to me is the number hospitalized. We have now been over 100,000 patients in the United States hospitalized and climbing for the last several weeks. This map came from the New York Times. There's a series of these so-called heat maps that show the hot spots in the country, and they're demonstrated in a couple of different ways. We're hearing about California and all the hospital overcrowding, particularly in Southern California, that's going on now. And if you look at total cases, Obviously, California is a populous state with these big dark bands in Southern California give you an indication of why the hospitals are very busy. But there's many other spots around the country that are also seeing a surge. If we break that down to cases per capita, here we are in El Paso right here. So we're still considered a hotspot, although things are getting better. So as is true of many statistics, it's not just the total number of cases, but it's also the number per capita, which gives you an idea of how much stress there is on the local healthcare system. So going back again to the beginning, you can see that we've had several surges. The early surge was largely focused on the East Coast. Back in April and May, we had almost no cases in West Texas, and it was a real disaster in New York, as I don't have to tell anyone who's watching from that area. Things improved over the summer, and then around mid-July is when we hit our peak, our first peak in El Paso. At that time, my hospital had about 62 cases, and things for us got better through August and September. And then we once again peaked about the second week of November when we went from 62 cases to 244 in my county hospital. And as you can see, we still have not peaked out on the current surge, bringing us right up to yesterday. Okay, moving down now to the state of Texas. This shows you our new confirmed cases in the state. Here again, you can see our July surge, and that was heavily in El Paso. As things improved over the late summer, we then started to hit a second peak in early November. Our peak was here, and as we're getting better, the rest of Texas continues to get worse. So one of the maps I looked at daily is this map of confirmed cases by county. And this is today's data. We've had 1.5 million cases so far in Texas. El Paso now is in fourth place for total confirmed cases. But if we look at active cases, we're now in second place. Until a week ago, and for the prior roughly 8 weeks, we were actually the #1 county in Texas for active cases at about 37,000. But our other big counties around Dallas, Houston, Fort Worth, Austin are now rapidly increasing. So there's a number of ways of looking at positivity of case load, case mix across the state. And this is one example. This was back in July, near the July peak, where we could get a breakdown of positive rates of tests across counties. Back then, El Paso was third at 11%. Hidalgo County was up at almost 25% positivity. The suggestion is if you exceed 10% that you're not testing enough. That if 10% or more of your patients are testing positive, you probably should be testing more patients. And this tracks that positivity rate from back in April through the July peak. So things were quiet, fairly quiet over the summer. And then at the end of the summer, things really picked up in terms of positivity rates. Here's a graph of total cases per 1,000 and active cases per 1,000. You can see that there's significant county-to-county variation. I can't tell you exactly why that is, except that it's a good thing that we all don't surge at the same time, because when we have been in surge, we've depended very much on help from nurses, doctors, respiratory therapists from other counties. So bed utilization, hospitalization is the most accurate number and the one that's most telling for how stressed the healthcare system is. And this shows you a graph for this month of December through yesterday of the whole state of Texas and the number of confirmed COVID positive cases in general beds and the available beds. The positives are red, and you can see we've gone from 6,500 to about 8,600. And we've not peaked yet across the entire state. In terms of ICU beds, there's been an increase, but not as great. We've gone from 2,540 to a little over 3,000 COVID positive patients in ICU. But a number of those general admissions will turn into ICU admissions, and ICU stays tend to be long. So this number is going to continue to climb. So now let me drill down in the last bit of time I have on what's going on here in El Paso County. Here we have a look from September through the 27th on our total number of active cases. We peaked out at about 37,000 and we've now dropped to 35. So this is one of the indications that things here are getting better. I really wondered about Thanksgiving and wondered if we'd have a post-Thanksgiving surge, and we have not. Our numbers have gone down since Thanksgiving, not gone up. The next big question mark is Christmas, and it'll be another week or so until we can see what effect Christmas has had on our numbers. Looking at predictions of the future, though, I turn to this statistic, which is the number of people tested and the number of them that test positive. The green bars were the number of patients getting tested. During our peak, when everybody was really nervous, we had a lot of folks coming each week to get tested. So at the peak, 53,000 people were tested in El Paso in 1 week. And the yellow line shows the number that were positive. The more people you test, the more positives you're going to have. So it's not just the number of positives, but it's the percent of patients testing positive that's important to look at. And here's a graph of the positivity rate. When we were at our peak, over 25% of patients who went for a COVID test tested positive. We dropped to about 7%, and now we're starting to creep up again a little bit. So this may represent some post-holiday effect. And I'm going to be watching this statistic very closely in the coming 2 weeks. This is a graphical breakdown by zip code within the city. Some of the more highly populated areas on the east side of our city that are more densely populated are seeing higher numbers of cases. If you're wondering what this black area is here, that's the Franklin Mountains. There's nobody living there. And then Fort Bliss is also up here, which doesn't have a high population density. If we look at who's turning positive and how that compares to the population as a whole, what we see, which I think is true everywhere, is that there's very few young children testing positive for COVID. The under fives represent only 2% of our positives, but it's 8% of the population. Same is true for the younger teens. 5 to 17 is almost 30% of our population, but only 11% of the COVID positive people in the community. 18 to 64 is where we see the bulk of our COVID patients. 3/4 of them are in this age range, but they represent only a little over half the population. And age 65 and above, it's similar numbers or similar percents of those in the community and those testing positive. Looking now at our hospitalization rate, you can see our peak here on November 12th. And in El Paso, our hospitalization rate has steadily declined. It's listed here as 441, but this data is 5 days old. We're now under 400. We're at about 380. Number in ICU is about 170, down from a peak of 330. And the number on ventilators has also started to decline, which is good news. When we look at the number of patients who are in general beds, from November 14, 16, when we were at 735, you can see here that we're now down to 217 in general beds. And when we look at the ICU, we've dropped from about 335 down to 171 over that period of time. So putting this all together, we've gone from around 1,100 patients down to 393 as of yesterday with COVID. The number of available ICU beds, which has been a real concern, has been hovering in the 50 to 65 range, but about 48 of those beds are at the Army Hospital, and they're not available to the general population. So we've been running on a very small number of ICU beds. When we look at the patients who are hospitalized and break them down by age, by decade of life, you can see the distribution here. The very young represent a very small number. If you look at those between 50 and 59 is this quadrant. The next group is here. And you can see that as we get into the advanced ages, this represents more than 1/3 of the patients in hospital. Looking at patients who have died that have been reported, the peak number of deaths has been in the 70s and 80s, and there's a predominant male distribution. the males being in the darker color and the females in the lighter color. So more than 2/3 of all of our deaths have been in male patients, and the predominance of deaths have been in the 70s, 80s, and 90s. And then the last statistic I want to share is ventilator use. There was a lot of discussion and a lot of concern about, will we run out of ventilators? I remember Governor Cuomo pleading for more ventilators from the federal government back in the spring. Well, we have not run out of ventilators. We never came close to running out of ventilators. This shows the number of vents in use by all patients, and the number of vents available is the lighter colored bar. We got into large numbers back in November at our peak, and this has steadily declined. So at no time did we have to worry about running out of ventilators. Now, whether we had ICU nurses and respiratory therapists to run them is another story. So in summary, there's multiple good sources of data. I found it incredibly helpful to monitor all of these sources on a daily basis and on a weekly basis to report results and my assessment of where we stood, both within my department, to share that information with our hospital leadership as well as with our border RAC leadership as we look to the future and plan for our surge needs. The numbers are not precise. Remember that active cases are simply estimates. There's no precise way to measure them. There's a real delay in reporting of deaths, so that doesn't help much in terms of planning. We see day-of-week variation as well as variation related to holidays. So these little blips are not meaningful in terms of the overall picture. There's probably a significant undercount of active cases and total cases due to asymptomatic patients who don't get tested. And there's probably a lot of deaths that are taking place that may be related, but not recognized as being related to COVID. So let me stop there. Gosh, I've used up half an hour of my 15-minute presentation, but I'd be happy to entertain some questions. And thanks again for inviting me to present this evening.
Thank you, Dr. Michelson. There's a couple of questions here. I'm going to present them on the board if you see them. Do you see that first question there?
Yes. Considerations for reopening schools in January. Boy, we all want our schools to reopen. I have a daughter who's a senior in high school and really wants to get back to school as we used to know it and not Zoom. I think school reopening is problematic because we're also getting into flu season. The good news is we've not seen much flu yet, but most seasons flu peaks in January and February. What we can't have right now is an added burden on inpatient beds from patients getting influenza. I don't think kids are at risk going back to school. I do think that there are asymptomatic kids who will share COVID with their classmates and bring it home to their older relatives who could end up becoming sick. So this is going to be a really tough thing to manage. Once we have more vaccination, it gets real easy. I'm hopeful that teachers will be in the next group to get vaccinated, so at least the teachers won't get sick from kids coming to school with COVID. But whether communities are going to be prepared to have schools open up and take the risk of new cases of both influenza and COVID-19 is going to need to be decided on a community-by-community basis.
The next question, I don't know if you see that one.
Yep.
Yep.
So, what, if anything, gives me hope about the coming months of the pandemic? Well, probably the biggest hope comes from vaccinations. During our surge, a number of our nurses ended up becoming ill and were sidelined. And although we made new beds, some 600 new beds in El Paso to deal with our surge, you got to have the nurses and the staff to take care of them. I'm happy to say that I received my first vaccination 2 weeks ago, and a week from Thursday, I'll get my second dose. 95% of my staff have been agreed to be vaccinated and have been vaccinated. My research staff are now all getting vaccinated so that we can get back to enrolling patients in COVID trials. And so I think vaccinations give us a lot of hope, and we can't get folks vaccinated fast enough, in my opinion. There's also some new therapeutics that I think will be available soon. I think that the monoclonal antibodies are a useful tool, and we know that there's other vaccines as well as other therapeutics that will be coming available that'll help us treat this disease.
I have another question here.
Has anyone looked at deaths due to depression and anxiety, which would be considered COVID-19 deaths, yet would not have happened if COVID was not creating such an emotional and psychological distress? Yes, people are looking at this. There have been recent articles, in fact, about increases in numbers of suicides, increases in numbers of drug related deaths. Sometimes it's hard to directly tie them to the pandemic. These are patients who probably were not infected with COVID, but their lives were very much affected by COVID, either from social isolation, from loss of employment, from financial stresses related to interruption in employment, from problems with housing or loss of housing. And the only way to really get our arms around the COVID effect would be to try to look at numbers this year compared to last year and look for changes. But yes, I can't quote you the publications, but they're definitely out there. There have been some lay articles in the New York Times recently talking about that.
Well, I just want to tell you, Dr. Michelson, thank you so much. I think we don't have any more questions here, and I really appreciate your expertise, especially during these trying times. So thank you.
Well, thanks for having me. I think we've learned a lot during the course of our going through our peak and now coming down the other side. I'd be more than happy to have folks reach out to me individually or to come back and talk a little more about how we handled our surge and some of the things that did and didn't work if there's interest in that. But otherwise, thank you again for inviting me tonight, for making this venue available to share our experiences. And I hope you all have a safe and happy New Year.
Thank you. Take care.